Okay, Chapter 5 provides information about the comprehensive audiology exam, some tinnitus information, and then some information about industrial audiology related to auditory processing evaluations. So most often when you are providing services for workers' compensation cases, they want a comprehensive audiological evaluation by an independent body or practice. And so by comprehensive, we mean air conduction, bone conduction, speech audiometry. Remember, air conduction, you want to include 3,000 and 6,000 hertz. Sometimes they'll request acoustic reflexes and decay and other. It depends on the company determining the case for worker compensation. So here's the U.S. Navy requirements. They want OAEs, ABR. They want you to test rollover. So think back to your early diagnostics course and what rollover is, why we test for rollover. But there you go. That's what the U.S. Navy requires. So the medical legal audiological evaluations, potential for medico-legal involvement because of the issues such as workers' compensation or fitness of duty for those in the military. When audiological evaluations are conducted, it's important to follow the protocols so the results are not questioned during the legal proceedings, whether it's for the military or otherwise. Of course, you have your case history. You need to be pretty thorough in your case history about the onset, descriptions of the different conditions or complaints, which include tinnitus, diplocusis. If you remember, that's when you have kind of differential pitch perception in one ear versus the other with similar hearing thresholds, hyperacusis, and then any other auditory processing difficulties. Of course, anytime we're doing any workers' compensation or industrial, you always have to worry about and think about non-organic type losses. Okay, when your audiometric findings are greater than poorer than you would expect or exaggerated among patients who are suspected to be malingering. Based on the audiometric test battery findings, exaggerated thresholds can be found in about 71% of the ears. So it's pretty common. And as you go through your career, you'll get very good at detecting this. I always, whenever I suspected any kind of potential malingering, I would start with speech audiometry. I would start at 5 or 10 dB to try to get an SRT. I never gave them a louder, starting at 40 or 50 dB and working your way down. I always started very soft. Didn't give them a reference point. Speech audiometry is a bit harder to malinger than the pure tones. Even with pure tones, I'd use an ascending approach where I would start at 5, 10 dB, see if I can get some responses before I would use higher levels. And we'll talk more about that. Underlying causes of non-organic hearing loss. Military personnel, when they retire, they have a percent disability, and so they can increase their benefits. That's why they have them tested outside of the military prior to discharge. And younger individuals, it could be attention seeking, that sort of thing. The underlying motivations among noise-exposed individuals for non-organic hearing loss can be conscious or unconscious. So, again, you will get pretty good at detecting this as you go forward in your career. So here are some reasons for referral under the following circumstances. A non-organic component or non-organic hearing loss should be considered a possibility. Failure to establish reliable air conduction thresholds. Referral for evaluation from lawyers, insurance companies, any worker compensation. Referral due to other related legal issues such as accidents, pensions, compensations, and so forth. So the precise test battery and the sequence for audiological evaluations in these contexts um, are shown here. And so this is quite the figure. But if we start, and I'm just going to go through it briefly, but otoscopy, ascending SRT, as I mentioned, I hadn't looked at this figure, but that's what I do. I start with speech, and I start very low and level. Unmasked bone conduction with the oscillator on the reportedly better ear, then air conduction, unmasked bone conduction with the bone conduction oscillator on the poorer ear, tympanometry. Now, again, this is just a suggestion, but it does not necessarily have to follow this. Everybody doesn't do it this way, basically. But I do agree with starting with speech audiometry and starting at a very low level and use an ascending approach. And I try to get an SRT in both ears at low levels before I would go to word rec at a louder, kind of more moderate intensity, because I'd like to get as much information to document the presence of a low SRT, if that's indeed what I think I will get. Okay, if they won't, if they are pretty good at malingering, then you can look into doing OAEs, the Stenger test, and other things like that, which we'll talk about. So the otoscopic evaluation, we know what it's used for, to look at the condition of the ear canal and the eardrum, free from impacted cerumen, to examine the possibility of ear canal collapsing. And essentially the way you do that is, what I have done is, you insert the otoscope, the speculum, in the ear, and as you pull it out, you kind of push on the tragus, kind of where the headphone would be pushing. So you push on the external, you basically push on the pinna some, and as you pull it out, you can see the canal collapsing behind it. So that's one way you can test for that. Remind me, and I'll mention this again when we meet in person. But that's one way you can test for potentially collapsing canals. So of course you know what the SRT is. Should be within about 8 to 10 dB of 500, 1000, and 2000 hertz, depending. If it's a precipitous loss in 2K is 40, 50, 60 dB worse, then you would use the Fletcher 2 frequency pure tone average. Usually in patients with non-organic hearing loss, 12 or more dB difference between this SRT and a pure tone average is indicative of potential non-organic loss. Again, we want to use an ascending approach. So in cases of unilateral hearing loss, no responses from one ear in the presence of normal SRT in the other is suggestive of non-organic hearing loss. So for pure tones following your SRT, they do recommend trying to do bone conduction testing first. Most people don't do that in my experience. And again, we use an ascending approach, okay, when we are testing air conduction thresholds. In most cases of noise exposure, the bone conduction thresholds mask the air conduction thresholds, obviously because we have a sensory neural component. Unless there is a conductive component, obviously, then they won't match. Bone conduction thresholds can be used to judge retest reliability. Knowledge of bone conduction thresholds before air conduction testing allows the determination of the need for masking and the amount of masking. And again, we all know that's a benefit for doing bone conduction first, but most people don't test bone conduction first. And again, here's some data from chapter 4. When you test 20 dB, when you test interoctaves, of course, when you need to use masking, testing 3,000 and 6,000 hertz. Now, there have been some problems with TDH39 headphones at 6,000 hertz because of their resonance frequency and kind of the issue of standing waves. So sometimes you might see this dip at 6,000 hertz because of standing waves. And so, you can avoid that by using insert earphones But just something to be aware of. Unmasked bone conduction threshold should be reestablished by placing the bone oscillator on the mastoid process of the reportedly worse ear. And again, these thresholds should be similar to those obtained from the better ear, because interoral attenuation for bone conduction is essentially zero, theoretically zero. But then when we mask, we want to obtain ear-specific information using masking and that sort of thing. Questionable tone of thresholds, test findings. So these are some pieces of information from the text. When you see increased variability in response patterns during ascending and descending trials, where you might get a response in a descending let's say 40, and then you get one at 30, and then when you go back and you're doing a different trial, they don't respond till 60 or 70 when they had responded at 30. So that's the variability. Threshold differences of greater than 10 dB during your repeat testing. 1,000 hertz. You do your retest reliability, and it should be within about 10 dB. Absence of false positives with an apparently higher number of false negatives. So people will essentially respond incorrectly at times. So if you have absolutely no false positives, it's likely that there's some lingering. Bone conduction thresholds worse than air conduction thresholds in the presence of accurate placement of the bone conduction oscillator. Absence of the shadow responses for unmasked thresholds in the impaired ear in cases of unilateral hearing loss. Basically, when one ear has normal bone conduction thresholds and you test and you're up above interoral attenuation, you should see this, what we call shadow response. Okay. Pure tone average is usually much worse than the SRT in most individuals who are faking, and again, the difference of 12 dB. Tympanometry is performed using a tympanometer, admittance bridge, middle ear analyzer to evaluate the function of the middle ear and to confirm or rule out any conductive component. Now, when we do tympanometry, that's not middle ear function. You can't say somebody has normal middle ear function based on TIMPs. You can say they have normal tympanic membrane mobility, but remember, in order to state definitively that they have normal middle ear function, you have to have reflexes at appropriate levels. So here's the shadow curve, okay? When you look at, so essentially when you're presenting at this level, because of interoral attenuation and them hearing it in the other ear, you would see a better response here, okay, than when you actually mask, okay? And so these unmasked responses are coming from the from the left bone conduction response, okay? So when you mask, you'll see the levels, the thresholds, essentially where they should be. So acoustic reflex threshold testing, of course, we talked about this. I'm going to give you an assignment to help you basically study for the praxis, help you study for this course. In normal individuals, reflex thresholds can be recorded somewhere between 85 and 100 dB. Okay, broadband signals, it's a little lower. Okay, reflex decay, tone is presented for 10 seconds, about 10 dB above the threshold, depending on the level of the threshold. And so you see this decrease in admittance. And of course, for 10 seconds, you see the response stays approximately, doesn't decrease by more than 50%. Wherein you have abnormal reflex decay, you see within the 10 seconds, you see a 50% decrease in response. And of course, these are used to detect retrocochlear pathologies. Here's some reflex testing where you can see this reflex threshold would be 85, right? And you can see at 80, there's no response. 85, there is. You go up and down until you find that first response. Okay, I'm going to make a part 2 for this lecture, so stay tuned.